According to my clock, it's a couple minutes after 1, so we will get started. Welcome everyone to today's session. This is the third of a series of 3 trainings about how and why evaluation can be useful to you. My name is Susan Jenkins. I am the Evaluation Officer for HHS, as well as the Director of the Division of Evidence Evaluation and Data Policy. And in my division, we oversee Title I reporting and materials for the Foundations for Evidence-Based Policymaking Act. Under that act, we were required to conduct a capacity assessment for HHS related to capacity for evidence building. And one of the areas that rose to the top was a need for better understanding of program evaluation among people most likely to benefit from it. Sort of a why should you be interested in evaluation and how can it help you? And so as I said, this is the last session of a 3-part series, and we will cover ways to ensure that the data meets your needs, how to identify high-quality data sources, how you can use data for programming improvement and budget justification, making evidence-based decisions. In terms of housekeeping items, before I introduce today's speaker, there are a couple of things. The slides for today's presentation are being posted in the chat, so you can follow along with those slides. We will post the slides for sessions 1 and session 2 at the end of the session today, and we are intending to post all of the slides for the 3 sessions, the recordings, and some associated materials in a couple of weeks on the M.S.P.H website, and we'll send out information about that so that you can access that information at your convenience in the future. Today's webinar is being recorded, and so we'll let you know when the recordings are available, as I said. And please submit questions for the speaker using the Q&A function. We will leave time at the end for Q&A, and we may answer some questions on the fly, but we will leave time for more discussion format Q&A at the end. So with that, I am extremely excited, just as excited as I was the first time and the second time, to introduce our speaker, Dr. Elizabeth Yano. Dr. Yano is an adjunct professor of health policy and management at the UCLA Fielding School of Public Health. Dr. Yano trained in healthcare epidemiology, biostatistics, and health policy at UCLA and RAND, and has over 30 years of experience in health services research and program evaluation. At UCLA, she teaches evaluation of health services in the executive M.P.H program. And so with that, Dr. Yano, welcome. We're so happy to have you, and I turn it over to you.
Thank you so much, Dr. Jenkins. Want to make sure you can see my screen all right? Great. So it's a pleasure today to talk to you about using evaluation to develop evidence with really a focus on making the most of your evaluation findings. As Dr. Jenkins mentioned, this is the last of the 3-part series focused on the key principles of evaluation in the federal context. And she already talked about what we'll focus on today, and that we will indeed make sure you have at least 10 minutes for Q&A, and we can respond further later on other questions. So let me go ahead and dive in. I start with describing program participants because you really cannot interpret program effects without knowing who participated in the program. For example, mortality may be high in a group you wouldn't expect it to be because enrollees were already very ill. Or, for example, maybe knowledge gain was high because only highly educated individuals actually participated and your target audience did not. You also can't generalize your program to other settings or other kinds of participants without understanding the people for whom it worked to begin with. So if we need to know whether or not participants are like or unlike others in important ways that would affect the likelihood the program would work for others. And then you have to think about what kind of characteristics will help you understand participants. That may be the basics of sociodemographics and socioeconomics. It's also, though, things like outcomes at baseline, meaning what was the state of function or other kinds of outcome measures before the program had a chance to do anything. And you also need to be thinking about alternative explanations like mental health or experience with other programs that may affect the extent to which you can say that your program had the outcomes of interest. So who we served and who benefited is critical for understanding also whether the program is actually addressing or unintentionally creating disparities. So let me give you an example up front of a policy evaluation. This is many years ago, but California terminated Medicaid benefits for medically indigent adults. So these were poor and medically needy adults that were not eligible for other federal assistance programs. So they were not blind, not disabled, and not in families with dependent children. Their care was transferred to counties, which were given block grants of 70% of the funds the state estimated would have been spent had the program remained in effect. Now, a policy evaluation found that these patients experienced in just 6 months a big drop in being able to identify a usual source of care. You see 96 to 50%, difficulties getting medical care when needed, 83% to 38%, and perceived their general health to have worsened substantially. And among those with hypertension, they saw substantial blood pressure control deterioration. So what do we need to know about these patients to understand those results? Where were they getting their care initially? What happened at the county on transfer? And were these changes just happening to other Medicaid patients too? Was there something else going on in the environment, or was it really because of this policy change? So let's lift the lid a little. Basically, these data were collected from Medicaid patients at one UCLA clinic. So are these impacts unique to this clinic? Maybe. We don't actually know. This small natural experiment was done on a shoestring budget by an early career UCLA clinical scholar. In fact, someone who went on to become an HHS assistant secretary years later. Were outcomes so bad because of who they chose to participate? Was it only the sickest patients? No, they actually included all of their English and Spanish speaking medically indigent adults who had used their clinic in the prior year. And of those, nearly 90% enrolled in the evaluation. So it was not a hand-picked or biased sample. Were outcomes so bad because patients were just dumped off the rolls from UCLA to fend for themselves? No. In fact, UCLA staff contacted all of their medically indigent patients and offered a free final visit to help them identify an appropriate county facility and make an appointment, and all were offered UCLA social work services as well. In fact, many of the clinic's physicians personally made attempts to arrange care for their patients with their counterparts at county facilities. So were these impacts actually attributable to the termination of their benefits, or was something else going on? For this, we would need a comparison group of patients like those who lost their benefits but didn't. And so they did just that. In this case, they used a comparison group of Medicaid patients from the same UCLA clinic. These were patients who were blind, disabled, or in families with dependent children, and then they worked to match them sociodemographically as much as possible. So in this table, you can see they actually did pretty well. If you take a look at the percent female, the percent in different ethnic groups, education, and income. Even with that, the comparison group was nonetheless slightly older and more ill. Why is that important? Well, to know that, you would need to see the outcome differences. So let me show you those. Now, in this table, you can see actually that the comparison group of Medicaid patients who, again, were slightly older and more ill, saw no declines in their usual source of care, satisfaction, or getting care when needed. And that's in addition to no changes in general health perceptions that's not shown here. And in fact, by 6 months, those in the comparison group had significantly better blood pressure control. So now we can put those evaluation findings in context. In this example, I focus on the Oregon Health Plan, which was a novel Medicaid waiver program that used a prioritized list of services to define their state benefits package. They then expanded Medicaid eligibility to cover all uninsured residents up to 100% of the federal poverty level. That increased coverage for about 100,000 folks and enrolled nearly all non-disabled Oregon Health Plan beneficiaries in capitated managed care plans. In this case, in contrast to the Medicaid example I just showed you, which managed to collect baseline data before benefits were terminated, these evaluators had no way to collect data before implementation. So they absolutely had to have a comparison group. So they chose food stamp recipients, some of whom were insured and some were not. Now you can see some of the differences between groups and then have to think about what that is going to mean if the evaluation results, for example, say the Oregon Health Plan performs better or worse compared to food stamp recipients. There's nothing anyone can do about there being more women in the Oregon Health Plan or that they were less likely to be employed. Now, if the health plan does better, I might have to think about whether it's because there are more women in it, since women tend to use more health care than men. If the food stamp recipients do better, I might start wondering if being employed is one of the reasons, and it has nothing to do with my program. For education, I can see that the Oregon Health Plan folks are more like the uninsured food stamp recipients than the insured ones. And so maybe I'll keep an eye on that comparison subgroup when I look at outcomes where education might matter. Now, the evaluators also looked at function and disability, and here you begin to see that the Oregon Health Plan folks had significantly lower physical and mental health function and a lot more disability. So if the Oregon Health Plan enrollees have better use, satisfaction, and outcomes compared to food stamp recipients, I'm likely to sit up and pay attention because their patients had major health burdens. So all in all, what they found was that compared to the food stamp recipients, insured and uninsured, the Oregon Health Plan enrollees were much more likely to end up with a usual source of care, have had a physician visit in the past 3 months, a visit to the specialist, and to be very satisfied with their overall quality of care. Now remember, they're more like the uninsured food stamp recipients, so they found the Oregon Health Plan enrollees were more likely to have had routine exams, blood pressure checks, pap smear tests, mammographies, a visit to the dentist, and have been able to see a chosen doctor along the way. So let's again go back to deconstructing those evaluation findings. What about those differences we talked about at the beginning? Being female or in poorer health could explain the higher use of healthcare instead of the Oregon Health Plan. So it was important for the evaluators to run statistics allowing them to adjust for those differences, for example, in gender, health status, and education. That helps us feel more confident in the evaluators' findings because the differences they found between the Oregon Health Plan and food stamp recipients are now more likely to be because of or attributable to the Oregon Health Plan. After statistical adjustment, the Oregon Health Plan was still associated with better access to a usual source of care, pap tests, dental visits, and access to needed prescription meds, regardless of the socio-demographic differences, not because of them. But how much of the Oregon Health Plan was about getting people insured? Well, the evaluators looked at this too. They compared everybody with insurance, so the folks on the Oregon Health Plan and the insured food stamp recipients, to the uninsured ones, and the differences they found ballooned. So why is this important? To show you that a well-designed evaluation can help you ask and answer a lot of key questions at the same time. So in this example, insurance is key, but not everything, since the Oregon Health Plan still did better than insurance alone. Lastly, I always like to think about what would have made the evaluation even better. Now, hindsight's 50-50, always, and I can't say I've read every one of the many published Oregon Health Plan evaluation papers, but what I want you to be thinking about is whether the design could have been stronger. For us, that often means randomly assigning people to one program versus another, if it's feasible and ethical. For this evaluation, they couldn't, but it's always worth asking if it is. These results also focused on survey data and did a great job doing so, but I would have loved to have heard about experiences in the enrollees' own words, qualitative interviews, for example, to help anchor and explain the findings and give us insights about where things could have been improved even further. Now, I took this one example out of a single published evaluation paper, and there are indeed many other papers from this team's work, but if this was the only one, I would be wanting to also see longer-term outcomes. Was the program sustained? And different types of outcomes like quality of care, and maybe different subgroups, namely how did children fare? In your roles, these are the kind of questions I want you to think about. So how do you know if the right measures have in fact been included? Well, you need to think about the factors that could affect program use as one starting point. So for example, if race ethnicity affects how people use or perceive services, you need to make sure you have a good measure of it and add those measures to help you understand how race ethnicity may in fact affect program use. for example, perceived discrimination. You also need to think about the factors that could affect outcomes other than the program itself. For example, you would need to measure age, diet, and smoking status in a weight loss program aiming to reduce heart disease. These are factors not associated with program participation, but may cause the outcome of interest: age, diet, and smoking affecting heart disease. So I'm going to take you through a couple of examples of how to think about these alternative explanations and other measures. The first one is some generic program, we're not even going to talk about what it might be, that aims to reduce mortality. So the first question you want to ask is, what else could cause mortality reductions other than my program? Well, advanced age, lack of exercise, low income, low weight, a male sex, chronic disease burden, sudden illness or injury, and risky behaviors like alcohol and drug use, smoking, unprotected sex, jumping out of planes. And what you need to do is measure those things to see if they caused your outcome instead of your program. The second example, you have a program that aims to improve knowledge. So again, what else could be associated with knowledge gains other than your program? Well, what affects someone's knowledge? Age, education, developmental and cognitive issues, attitudes and values, health problems, peers, and family cohesion, and a lot more. So again, you would need to measure these and or exclude people unlikely to benefit from the program, such as cognitive problems, which becomes a sampling decision, thinking about inclusion and exclusion criteria for who would most benefit from participation in the program. What are the consequences of not capturing some of those right measures? Well, this is another older evaluation, but some early national work reported hospitals with very high mortality rates. And it frankly sounded like big academic medical centers like UCLA were killing people outright. It really was quite dramatic in the media at the time. So how do you even figure out what this means? Well, you better understand the characteristics of the hospitals with high versus low rates. And what they found, perhaps not surprisingly, was a lot of tertiary care hospitals among those with high mortality rates. Well, then you also better understand the characteristics of patients being seen in those hospitals. And it became clear that early analyses may not have adjusted adequately for patient sickness and comorbidity. The work also had not really adequately taken into account the referral patterns that happen, meaning smaller community-based hospitals typically refer their sickest and most complex patients to big tertiary care facilities, where in fact some may pass away. So after adjustment for these measures and others, the meaning of the results flipped, and you ended up walking away realizing it's actually best to get yourself to a big tertiary care hospital for certain conditions and complexity. There's another important alternative explanation to why your program might look like it works in contrast, and that would be something that people were exposed to that actually caused the outcome that had nothing to do with your hard work. An example here is, let's say you're overseeing a program to increase colorectal cancer screening rates, and change just seems out of reach. You're really not able to move the needle. But then suddenly your evaluation data shows that colonoscopies are soaring. Now, do you celebrate? Probably not. Do you rapidly expand the program and its reach? Probably not, because there's nothing that actually changed in the program itself. So now you have to ask the question, why would outcomes increase on their own? And what will help you figure that out is probably interviews or survey data among colonoscopy completers to find out what actually got them to do this, and then comparison data from those not participating in the program. And some folks did this kind of work and illuminated the Katie Couric effect. Now, Katie Couric was a well-known, at this time, TV news anchor whose husband had prematurely died of colorectal cancer. And she actually televised her own colonoscopy to eliminate some of the stigma and improve people's awareness that this is not that big a deal in the scheme of things. So that's actually what ended up causing those soaring rates. Now, you can't probably celebrate your program's effectiveness, but you also learn some important information about how people respond to information. And of course, the flip side is that celebrity sharing can spread misinformation and dampen what your program might be able to accomplish too. These are just things to be thinking about along the way. So I've taken the time to get you to think about, hopefully, the measures needed to understand who participated and what else could have caused your program outcomes besides your program. So let's go back to the meat of things, namely your measures of program effectiveness. Last time I talked about the importance of engaging key agency personnel and other stakeholders in prioritizing outcomes without listing the most common ones, and here they are. Knowledge, attitudes, beliefs, and behaviors. Quality of services, utilization rates. Now, these are commonly measured, but the challenge in figuring out the effectiveness of a program and utilization is to know what a good rate is. Is more always better, or does it become overuse and not beneficial at some point? And I would also be careful when we talk about productivity, workload, and efficiency, that for efficiency, I wouldn't measure it without balancing it with some kind of measures of quality, as you can squeeze efficiency to the point where services are no longer worth the price being paid. There's also measures of function, like activities of daily living, quality of life, and other health and human services, such as health status, literacy, food insecurity, housing instability. Any of these can fit, or there could be more specific versions of any of these for your particular program or policy. The other thing I want to say here is that it's really important to go back to the original program intent and any guiding documents to ensure you're gathering data on the outcomes that were relevant for that program's building in the first place. So how should you think about measuring quality of services, for example? You may be able to ask participants to rate the quality of what they got, but you need to ask yourself whether they are in fact good judges all the time. They can rate the quality of their experience and how satisfied they are, but will they actually know high quality service content from low, especially if they've never had access before? For example, at one point I found that actual technical quality of care and patient ratings of care were negatively correlated. So just because a patient's happy doesn't necessarily mean they're getting high quality. For example, someone can love their doctor because they don't prod them about losing weight or stopping smoking, even though we know they should. Having explicit criteria for and objective criteria for high, medium, and low quality can help. For example, I evaluated a VA primary care program quality after a national policy shifted to team-based care models, and I used a national org survey to measure attributes like the presence of a patient education center. And I was thinking that high quality primary care would invest in patient education to support chronic disease self-management, enhanced shared decision-making, and other good things. I then traveled to sites that scored well, including checking yes to having a patient education center. So I asked to see them. In my first site visit, they walked me to a large suite of dedicated offices with classrooms staffed by 2 full-time educators, replete with workstations and a library of videos and other resources. And I thought, this is what a yes was supposed to be. I went to the next site and I asked to see their patient education center. And after some confusion, I was unceremoniously shown a cart of dusty brochures in an unused corner of the clinic. Needless to say, I had to revise our criteria. But these are the kinds of things you want to be thinking about. Now, health status, there are many ways to measure health status, including asking a patient to self-rate their health as excellent, very good, good, fair, or poor, which is surprisingly predictive of morbidity and mortality. Or you could rely on family input, especially if the patient may want to look good in your eyes, or providers or nurses' ratings or chart reviews. What's key is the answers you get may all differ, so you have to think about whose perspective matters. Now, there's also measures of quality of life or quality of death and dying on the other end of life. So you have to think through what aspects of quality of life you care about: physical function, mental health, pain, ability to do your usual daily activities. And realize that whether it's quality of life or quality of death, there are strong built-in personal values. So you have to think about whose perspectives, again, matters: the participant, their family member, or the provider. Homelessness is another example where it may be better to think about housing stability and independence. If you think of homelessness just as someone who's living under a freeway somewhere or a housing encampment, you're going to miss some of the bigger pictures of people who do couch surfing, where they don't actually have their own place to stay, but they shift from friend's house to friend's house to friend's house. So again, thinking through those conceptual issues and the reality of the experience of the people you're implementing programs for becomes really important. And lastly, for organizational culture, this is another one where perspective matters. For this example, I did site visits to assess organizational culture and how it influenced program outcomes. And I went to a variety of sites and I heard from the director, the culture here couldn't be better. From the service chief, well, we work really hard on it. And then as our interviews continued, the cracks started showing, such that by the time we spoke to frontline providers and staff, you could tell that the place was simply going to blow. It's awful here. No one listens to us. So again, perspective matters. Now let me shift to another important topic around general evaluation data considerations. The availability of data is something you're going to have to figure out, whether you're collecting it de novo or in fact have existing data sources. If you're working off of existing ones, you have to make sure they have the measures you need, which is why you have to go through all that exercise I've been talking about making sure you've fleshed out, ferreted out what measures are important to have. That you then have to figure out who actually has the data, what it will take to access the data, how long will it be before it'll be available. I didn't put it here, but also whether or not what it's going to cost to get those data. And then I want you to be thinking about the quality of data, because just because data exists already doesn't mean it's any good, which is fretful. But you need to make sure whether or not anyone has tried to validate the data for accuracy, or whether or not the data are in fact reliable. Are they in fact complete or reproducible? And if surveys are used, it's always important to think about whether or not the evaluator has relied on reliable and valid survey measures, things that other people have tested that have predictive validity for the outcomes that you're interested in, are sensitive to change. And so these are the kinds of things you want to be thinking about, because if they're going to develop something brand new, it's going to require its own pilot testing and its own work over time. Data usability. Here, it's really important to think about how easy it is to use or understand the data that you're getting. There are usually hoops to go through to get access to identifiable data, for example, think HIPAA and other regulatory issues. And some databases don't even have a way to identify people, so it's important to know that up front. Similarly, anonymized data collection will not be your friend when it comes to trying to merge multiple data sources and analyze data, so better to know how data are organized early on. Costs of data collection. That could be its own session or series by itself, but what I want you to think about is how easy or hard it is to be collecting data from program participants. So if you want to collect surveys from participants by phone, for example, you will be competing with faux market research and others who have tanked people's trust in a phone call for information. Similarly, getting people to click on a web link by now to do a survey requires enormous trust for fear of getting a computer virus. And surveying or interviewing busy providers and staff can also be hard and take more time. For example, you may have to go to their location, get to one of their meetings, sell the evaluation. Why is it worth their time to participate? Getting leadership endorsements and more. The other issue here is to think about how big a sample you need to collect data. Is it a matter of fewer than 100 people, hundreds, thousands, tens of thousands? Now, if you are sending out self-administered surveys or web links where you're not around when people are hopefully completing the surveys, the volume of participants may just be an incremental cost further, right? It's another stamp, it's another set of emails that will go out. But if you're actually doing interviewer administered surveys, every increase in the sample size is a direct one-for-one increase in someone's time to conduct those surveys. And of course, given my first comment here about ease or difficulty in collecting data, there is always work in getting people engaged enough and informed enough to be even willing to participate. So these are just some general considerations I wanted you to think about. So this last segment of our session today is really about using data and thinking about translating evaluation findings into usable information, answering questions in a way that doesn't require your being a statistician, thinking about why programs did and didn't work and what you're going to do about it, and then approaches to making evidence-based decisions based on evaluation results. How do you know if you have enough information to act? the value of experts and stakeholders in supporting you, and the importance of contextualizing evaluation results along the way. So this is a reminder from part 2 using the HIV Quality Improvement Program example, where the program itself included physician training, audit and feedback of practice, a comparison to guidelines and to other practitioners, and bonuses to doctors who were able to improve their guideline knowledge, their guideline adherence, and satisfaction on the path to improving for the overarching goal, the improvement of patients being on antiretroviral therapy appropriately. So let's focus on one of those evaluation questions, the impact measure. Was the HIV QI program associated with increased highly active antiretroviral therapy use among participating physicians' HIV positive patients? So when I think about that evaluation question and I want to understand the evaluation results, I'm not even showing you any results here. What are you going to want to see in those evaluation results? First, you want to see an outcome change before and after program participation. If there's no change, it's time to see what level of program participation or dose actually occurred, thinking amount and duration, or was, as you were training physicians, were they all getting their pagers going off so they had to leave clinic suddenly? Or were there other challenges in getting people to get through the entire set of program activities? Again, if you don't see an outcome change, it's time to look at the process evaluation, which we talked about previously. Was the program implemented as intended? Again, if you see no change, I want you to think about why else the program may not have been effective. Is getting physicians to improve prescriptions enough to get their patients to actually take them? Or in fact, do we need to add something to the program to beef up our ability to accomplish that impact goal? I also would want to see a description of the program physicians at baseline to help me think about what about them may have helped the program to be effective or not. Maybe it's specialty training. Maybe it's years since medical school, that there's issues about older physicians, greater years since medical school having much more experience, but also farther away sometimes from new technologies that have emerged. So there's not a good or a bad, but there are differences. There may be attitudes towards HIV care, or maybe you need to know how many patients with HIV they've actually had in the past year to give you a notion of, in fact, maybe they see a lot, and your education and your training and your engagement here really doesn't make a difference because they know what they need to know. So those are some of the questions I would want you to be thinking about. The other thing I'd want to see in the evaluation results is an outcome difference, if possible, between program physicians and comparison group physicians. I want to see a description of both groups, and I want to see whether or not they're inherently same, apples to apples, or if they're different in important ways, apples to oranges. If they're different, I want to see that the outcomes analysis, in fact, adjusts for those factors statistically. So, for example, if the program physicians are significantly younger than the comparison group physicians, I want to see that somebody adjusted for age, okay? Now, I also want to know what the comparison group physicians were exposed to. If the program does not look like the program physicians did better in any of those outcomes of interest, maybe the comparison group docs actually have already managed to do something that improved their care dramatically. This happened to me in one of my studies along the way, where the comparison group folks were in fact a leading set of experts. So you want to make sure that their business as usual is something you actually understand. And then lastly, I want you to be thinking about potential unintended consequences. Maybe incentivizing physicians instead of the entire care team created unanticipated problems. Or maybe improving prescription rates rapidly created a workflow burden for the pharmacy, and that slogged down the ability of the program to make further progress. This happened in a depression care evaluation we did once, where they increased demand among primary care providers for a depression care manager who then got overloaded and was unable to, in fact, do her job. Let me give you another example. Improving smoking quit rates. Smoking, I think we can agree, has an array of adverse health consequences. About 12.5% of all Americans are smokers, so that's almost 31 million people. still. For us, about 33% among veterans still smoke. And yet there's many smoking cessation programs that work. Nicotine replacement therapy, brief provider tobacco counseling, smoking cessation clinics, quit lines. And yet adherence to smoking cessation guidelines continues to be low. And they recommended multifaceted smoking cessation programs. So not just one of those things I just listed, but a set of them to enhance effectiveness. That means, though, you need to get organizations to adopt them, and you need to get providers to change their practice. So we evaluated a multifaceted approach to improve smoking cessation guideline use. It was guideline education, local stakeholder panels for changing behavior, quality improvement training, some data feedback, and some external facilitation to help move them along. The participating practices could choose which evidence-based programs to implement. And the long story short is targeting primary care referrals to smoking cessation clinics, which is the gold standard of the evidence in the literature, did not improve quit rates. Now what? Well, in this case, practices were randomly assigned to experimental and control groups. We're supposed to celebrate that, right? That's the gold standard for evaluation when you can pull it off. And that should have helped make the two groups comparable, but randomization didn't work. If you look at this example, the smokers in the control practices were more likely to have been prescribed nicotine patches, referred to and attended smoking cessation programs, and prescribed medications. So just at baseline, they were way better off than our folks in the intervention practices. The practices also had big plans that were not evenly implemented, and they often ignored external expert input and facilitation. And some of these folks were truly national experts in smoking cessation. So it was important for us to learn that, in fact, an external expert is sometimes shunned compared to local experts and what people like to do in usual practice. I just wanted to show you this example because you can see that there could be really strong intentions to implement the program. And here you can see provider education, patient education and activation, provider profiling and feedback, primary care-based organizational changes like instituting a brief counseling program, a computerized referral in primary care, or hiring a counselor or nurse hired in the smoking cessation clinic. And despite the best intent, only a fraction of those actually implemented them. And then there were other things that were more rare, like smoking cessation clinic changes and provider incentives that they did actually do. What we also learned was that practices often redirected their time and attention and resources to other good ideas that were not evidence-based. So it's important to remember practices have their own cultures, their own staffing, their own experience, and the program may run counter to those things. So I want you to again be thinking about measures and collecting data in a way that allows you to discern what happened with the program. And this is just an example. This was an 18-site study, but in these 7 sites, you can see a high variation in the number of planned evidence-based changes, the decrement in those that were actually implemented. So this first example, 4 were planned and only 1 actually happened. And then they added 2 that were not evidence-based. Now, the problem with that is implementation of something else that's not planned or evidence-based still takes time. So there's opportunity cost in adding these new things, but then you still see that there were challenges in implementation. So more work definitely would be needed to help this program work in the scheme of things. So how do you know actually then if you have enough information to act? If the program worked, I'd recommend you go through the following exercise. Go back to wondering whether or not and checking whether or not the results meet your standards of effectiveness you set out at the beginning, whether that was statistical significance or something else. I want you to think about what level of evidence or impact was found. Was one outcome really improved, but 5 others declined, or was it more consistent? Having what we call mixed outcomes is not uncommon at all. So then the question is did you learn enough from those outcome differences to refine the program to potentially improve those other 5 outcomes? Or is it possible that the program simply needs more time to have the intended effects? If you see some movement in outcomes, it may be one of those situations where it's not statistically significant yet, but if you keep moving in that direction, things may improve. Then you need to think about whether or not the program worked evenly or equitably for all participants. Did it, again, improve outcomes for some, but not others. That's really important to consider. And then there are some policy decisions to make. Do you continue the program for those who benefited? But if so, what are you going to do for the folks who did not benefit? Well, you may adapt or tailor the program to address the needs of those who did not benefit, but then you better reevaluate to make sure you've in fact met their needs. So there are decision points there as well. These are important questions to ask even if the program did not work. Do you have enough information to guide now program changes and evaluate again? Or do you indeed have to go back to the drawing board? I'd say for the example I shared with you on the smoking cessation project, they used the results to shift all the primary care practices to quit lines and then identified new comparison practices and found that the quit lines were easy for people to implement, easy to get them to change their behavior. It didn't add work to primary care providers who were already burned out and busy, and in fact was quite successful. So no matter what, you can use evaluation information to make important evidence-based progress. Now, I also said I would talk to you about getting help in evaluating the evaluators, whether the evaluators, as I mentioned last time, are in-house or outside. There's obviously substantial evaluation expertise within your agency and outside. And I would say build off of those existing resources and learn from prior evaluation efforts. It's very helpful to also arm yourself with experts and stakeholders who can often bring key perspectives that improve the evaluation quality and your ability to act on evaluation results. We talked about some of that last time as well. My main point here is that tapping such expertise can be an insurance policy for you. It can help you review evaluator qualifications. Maybe their experience is highly relevant, but maybe not. Maybe they can help you take a look at the quality of work they've done. They can help you review the quality of methods, both those that are proposed and as it's conducted. It can be very helpful to get others to review survey content, the measures used, given all the examples I've talked about today, the response rates and how to handle those if they're low, the evaluation design, and more. They can also be really helpful to review the quality of results and help you with their interpretation. And that includes sense making, especially with more complex evaluations and a lot of parts and pieces that may or may not tell the same story. This expertise can also help you with contextualizing evaluation results compared to other programs, other evaluations in the agency, or compared to the published evaluation literature. It can also be important to have these experts in your hip pocket with pushing back if need be. If the results of an evaluation are unclear, or if you need more analyses done, having that kind of group think and group support for in fact needing something else and pursuing it can indeed be helpful. So in summary, I've also wanted to make sure it's clear that you need to put your evaluation results in context. You want to stay anchored in who the program served, how and why, and keep your fingers on the pulse of program progress on your agreed upon goals and measures. Think about the types of individuals served, the types of program staff involved, the settings in which the program was delivered, and the areas in which they operated. And think about what do these actually mean for what happens next? Because the evidence-based actions may include program refinement and more evaluation, subgroup tailoring, more evaluation, and spread and more evaluation. And then think about what was known about effective programs before you started and what the evaluation has added. Was this a major contribution, some incremental gain, or a bust? Now, if your work is driven by solid evaluation evidence, you never lose. You only learn as you make evidence-based improvements over time. And further, as evaluation evidence builds, so will the program impacts, because you've created a foundation for opportunities to inform program and policy advances within and across your part of the agency. So with that, let me go ahead and shift our time to question and answer, and I'll stop sharing so we can see people.
Thank you very much, Dr. Yano. Again, another very informative and friendly, welcoming evaluation presentation. So we hope that this has helped a number of people better understand what evaluation is, how it can be helpful, how it can be useful to you. We do have 2 questions in the question and answer area. Other folks, you can still put questions in there. The first one is, what are some tools to determine if qualitative or quantitative data will best fit the needs of the evaluation?
That's a great question. And I'm not aware of specific tools per se. What I have found over time is that we work to include both qualitative and quantitative methods, or what's often called mixed methods, in virtually all of our evaluations. And it's because of the different values that the different value that they generate for being able to understand what the program in fact accomplished, both in a quantitative way and in qualitative experience, and in helping you continue to make evidence-based changes. So I don't know, Dr. Jenkins, you may be familiar with specific tools, but we'll answer that more fully afterwards as well.
I'm not aware of a particular tool either. I think it is the discussion, as you've been describing, what are the needs of the evaluation, what types of data are available, what is the purpose of the evaluation, that kind of thing. And I should note, thank you, Dr. Yano, for reminding me, that all of the questions that we've gotten over the 3 sessions, we will be generating a question and answer document that gives more full answers than what we're able to give in the session today or the previous 2 sessions. The second question we have is, how would one go about further developing their data analysis skills for an evaluation?
That's another great question. Most people will not be able to stop what they're doing and head back to school for a master's in public health and the like. And it really depends on whether or not you are thinking about explicitly being the hands-on data analyst working with the data, or if you are the person guiding someone else, doing what I call shell tables, fleshing out an analysis plan. I think there are probably applied workshops and courses out there about honing some data analysis skills, but they may or may not be relevant to Health and Human Services. So I think that would be one of the potential challenges. I think that would be probably what I would tend to recommend, is kind of workshop-based programs that help you hone skills. But you'd also need to make sure that they fit what your current skill level is, so that you can go from basic to moderate to advanced. Or if you're really advanced and you're really focusing on, gosh, I want to know how to analyze pragmatic trials, and there are actually like one-day workshops just on things like that. So I think that it's important to gauge where you are in your skills, and also see whether or not there are quantitative or data analysis teams in other parts of the agency. I often put together national work groups of people who are doing similar tasks, whether it's qualitative interviews or certain kinds of big data or survey analyses, and bring them together so that they can cross-train and learn from each other. And that seems to be an effective way of working within an agency as well. I don't know if Dr. Jenkins, if you have other things to add.
Not at this moment. I think as we develop the broader written question and answer document, we may have some specific outlets, some specific resources that we can recommend to help. We did get a third question. How do you ensure your questions are neutral when developing a survey?
That's a great question. That's another one where one could have intensive training in survey design and development. The short answer for that one is if you're really developing something de novo, meaning there isn't an established, validated survey instrument or measures or scales, that it's very good to develop a set of survey questions where some are positively worded, some are negatively worded, so there's some balance there, that you get someone else to read them and also give you direct feedback to say, wow, that one's kind of charged, or to consider having a pilot testing those as well among people who are like those that you'd like to administer the survey to, so that you get what we call cognitive interviews done. When you read that question, what does it say to you? What does it make you think about? Where does it take you? And you'll very often find people informing you just directly that the question takes them to a place that is not your intent, or pushes on a topic in a way that is not neutral, as you're pointing out. So there are definitely resources and tools out there for survey design and development. And I think we've taken a look for some tip sheets. There may be some in that area, but I always make sure other people are reviewing my surveys and also pilot testing till I think we've gotten it right.
The only thing I would add to that is also look at the response options that you give. So for a closed-ended question where you let people pick one or more of the response options, in addition to looking at the question, look at the response options also. If they're weighted in one direction or another direction, you do have a problem. So that's another thing to do.
Yeah, I had someone do a survey where they were asking about the impact of COVID-19 on primary care delivery, and the questions were a little positive impact to a big positive impact, and of course it was like, well, wait a minute, what about the negative impacts? You know, and it was just simply unbalanced, and it also represented the people with whom we did cognitive testing, because they all thought it was fine, and we got to several people who thought it was absolutely not fine. So you just need to broaden that. But the response options are very important.
So we have 2 more questions now, and I think those will be the last 2 that we take. But if people have questions, put them in the question and answer, and we will put them into the document that we produce and that we post on the ASPE website. Actually, we just want one more question. Do particular stakeholder types tend to prefer different data collection measures?
So great questions. Yes, I'm done. No, yes, because there are some groups that think qualitative is like data light, like it is not rigorous, it is not solid information. They want statistics with p-values that they can report up the chain. And so there are some people that are very anti-qualitative information. I have to say, as an epidemiologist, I used to feel like, give me a survey of 10,000 people and I could tell you the meaning of life, until I started to learn more about qualitative data. And I found the richness and the information that went deeper and in ways that allowed me to understand my quantitative findings in a way that simply weren't possible before. As I mentioned, I'm not a good qualitative interviewer myself, but I am sold on what value add there is. Now, the flip side is it can be difficult to have a qualitative only evaluation, depending upon the size and the complexity of the program that you're evaluating. So there are some stakeholders that only want the stories. And they just kind of assume you've got the quantitative stuff, but they need the story. And because of the fact that there are indeed preferences, that's why else I tend to recommend a mixed methods evaluation, because you need to be ready to respond to all the kinds of stakeholders you have.
Yeah. In addition to that, when I worked at the U.S. Peace Corps, we found that there were some communities that really preferred face-to-face interviews as opposed to surveys, you know, and so there are also all of those types of things to take into consideration as you're thinking about what data collection methods you're going to use, how you're going to structure them, those types of things. So there are a lot of different things to consider with that, but I go back to what Dr. Yano said. The short answer is yes. So with that, I want to say thank you so much, everyone. We do have a poll. We, as evaluators, want to make sure that you evaluate us in terms of what you liked about this session or what you did not like about this session, to be balanced.